What happens for some different reasons, we don't know the exact reasons, there are different theories. This endometrium is located in the ectopic position. Ectopic position means whenever something is located in that position where it should not be located, this is called ectopic. Like you have heard of ectopic pregnancy, where the pregnancy is not located inside the pregnancy. Similarly, if endometrium is located outside this normal position, then this is called ectopic endometrium, this is called endometriosis. Suppose it may be inside the ovary, it may be inside the tubes, it may be outside the wall of the uterus, this is called something called adenomyosis. If it is happening in the ovary, it causes cyst formation, this is called chocolate cyst or endometrium. It can have in surrounding organs like bladder, bowel, even in distant organs like in the lungs, in the liver, various organs. What happens? This endometrium also responds to the hormones secreted from the ovaries. So this endometrium, suppose there are ectopic endometrium, this is the ectopic endometrium, this also responds to the hormones. This grows, again progesterone acts, then it sheds down. The normal endometrium, it has the opening, it can shed down through the vagina, but here there is no opening. So the blood, because when the endometrium is shed, there will be accumulation of blood. From uterus, the blood can come out, but from this ectopic tissue, the blood cannot come out. What happens? This blood accumulates. It leads to formation of cyst. This is called chocolate cyst because old blood is chocolate colored, not bright red. That's just chocolate cyst. If it is happening in the wall of the uterus, this is called adenomyosis. There is another important thing, the most important thing it causes, this is called adhesion. This is the abnormal attachment between organs. Suppose uterus is attached to the ovary, ovary is attached to the intestine, intestine is attached to the urinary tract. So all the organs are attached together, plastered together. We call it frozen pelvis. What happens? Because these organs are attached together, they can't move normally. So it causes pain. And there are another reasons for pain, like this causes stimulation of nerves, so that's why there will be pain. And again, because in normal condition, this uterus, this is the tubes and this is the ovary. Sperm reaches inside the tubes and eggs is released from here and eggs reaches here. What happens in endometriosis? Because all these organs are plastered together, the tube cannot take the egg from here. And there are also other reasons. There is something called inflammation. As a result, sperms are damaged, the eggs are damaged. As a result, there will be no pregnancy. So there are two symptoms of endometriosis. Mainly one is pain, another is infertility. Although there may be some symptoms that may be overlapping. Like sometimes this can be like irritable bowel syndrome, like features like patient can have gastritis, bloating, etc. Some patients may have shoulder pain. Some patients can have fatigue. But two most important features are pain and infertility. And pain can be of different forms. It can be, we call dysmenorrhea, pain during menstruation. It can be dyschezia, that is pain during passing the stool. It can be dysuria, pain while passing the urine. And some patients, particularly if the endometriosis happens inside the bladder, they can have cyclical hematuria. That is, during the time of period, they have blood in the urine. Some patients can have blood in the stool during the time of period. Sometimes endometriosis may be deep inside the vagina and it causes dyspareunia, painful sex. And some women can have pain throughout the cycle, which causes chronic pelvic pain. And some women can have infertility. But surprisingly, endometriosis can be asymptomatic. Some women may not have any symptoms and even they don't know that they have endometriosis. Like suddenly when we are doing ultrasound for some other reasons or when we are doing cesarean section, we discover that there is severe endometriosis. And another important thing is that severity of the disease always does not correlate with the symptoms. Patient with minimum endometriosis can have infertility and severe pain. On the other hand, patient with severe endometriosis may not have pain at all. So the treatment depends on mainly two things. Number one, the pain, and number two, the infertility. If there is pain, we need to know whether patient wants to conceive or not. She is not planning or she may be planning for pregnancy. If she is not planning for pregnancy, we have two options. One is the medical management, another is the surgical management. First, we usually try medical management in the forms of various hormones. The aim is to dry up this ectopic endometrium. See, the main culprit is estrogen hormone, because estrogen causes proliferation of this endometrium as well as this endometrium. So if we can stop secretion of this estrogen, or if we can prevent action of this estrogen, this endometrium will dry up. But one thing we have to keep in mind, endometriosis cannot be cured. It can be kept under control. There are only two ways of curing endometriosis. One is natural, when the woman reaches menopause, that is, ovary stops secreting estrogen, or if we can remove all the organs like uterus, ovary, everything, then only endometriosis can be cured. So for medical management there are different options, but one thing we have to keep in mind, pregnancy is not possible, because either these hormones causes prevention of release of hormones from the ovary. Sometimes these hormones can cause prevention of ovulation, so eggs will not be released. Or sometimes these hormones can cause drying up of this endometrium. As a result, pregnancy will not happen. So if the woman plans for pregnancy, medical management is not possible. Of course, we can give some painkiller medicines at the most. Now suppose the woman is not planning for pregnancy, so we first try medical management. If that's not working, then we go for surgical management, ideally by laparoscopy. After surgery, we have to see whether the woman wants to conceive after surgery, because we have to remember, immediately after surgery is the best time to conceive. If the woman does not want to plan for pregnancy, we give long-term hormones, so long as she does not want to conceive, because endometriosis will recur. Whatever treatment you do, you stop medical management, endometriosis will recur. You are doing surgery, maybe after 2 or 3 years, endometriosis will recur. Recurrence is the rule of endometriosis. If it does not recur, it is the exception. So if the patient wants to know, doctor, can you give me guarantee that it will be cured? We say no. We can only give one guarantee, that you will have recurrence of endometriosis. Now suppose if patient is planning for pregnancy, what happens? We can't use medical management. Either we have to go for surgical management, or sometimes no treatment, we can directly go for pregnancy management, the fertility management, directly go for treatment for pregnancy. It depends on other factors, number of eggs inside the ovaries, husband's sperm counts, etc. Basically, we have to see whether there is chance of natural conception or not. Usually, if endometriosis is very severe, like grade 4, we say that chance of natural pregnancy is minimum, so you better go for IVF. Or there are any other reasons like tube block, or there are severe problem in the sperm, go for IVF. If there is enough reason to believe that she can conceive naturally, we can try natural conception. So, if she is planning for pregnancy, medical management is a big no. Only thing is that suppose she is planning for pregnancy, but she is bothered too much about the pain and she wants to defer pregnancy. In that case only we can try medical management. Before surgery, medical management will not help, particularly in the context of pregnancy, and immediately after surgery, medical management should not be given, because immediately after surgery is the best time to conceive. And another thing we have to remember when we are advising surgery, basic principle is that surgery will reduce the pain. Surgery will improve the chance of natural conception, but surgery will not improve the chance of success of IVF. Suppose she needs IVF for any reason, maybe sperm problem or maybe tube block, straightforward we advise go for IVF, don't go for any surgery. If there is no reason to go for IVF now, we can try surgical management, or sometimes no treatment at all, because always endometriosis does not need treatment. So if she is planning for pregnancy, again you have to look without the pain. If the pain is severe, surgery. If pain is not severe, then depending on other factors, surgery, or directly go for assisted technique. So medical management comes only when she. What we can do? We can either stop the action of secretion of estrogen by various means. We'll go to it later on. That is GnRH analog. Or number 2, we can antagonize the action of estrogen. That is, we are not stopping the secretion of estrogen, but we are stopping the action of estrogen in the ovary. Either we can use oral contraceptive pill, we can use various form of progesterones, Dienogest, norethistérone, and sometimes we can use this Mirena, that is levonorgestrone intrauterine system. previously in like danazol was used, but it is not used nowadays much because it is androgenic. It causes like excess testosterone, features of excess testosterone, so we don't use it. And there are some evidences because estrogen is the culprit, so we can stop the action of estrogen by using letrozole here. So we'll mainly progesterone Dianoges, we used it for long period of time. We used to use oral contraceptive pill, but it's better not to give oral contraceptive pill in cyclic manner. Rather, we should make the patient amenorrheic, that is, we should stop her menses altogether by giving continuous oral contraceptive pill without gap. Even in Dianoges and other treatment also, we are doing the same thing. Oral contraceptive pill advantage is that it's cheaper, easy to take because it's available in tablet format. It also provides contraception. Problem is that there are some women for whom we can't give oral contraceptive, but like women with liver disease, women who are very much obese, who are smokers, who are at risk of thrombosis, or who are at risk of cardiovascular disease. Progesterone, particularly Dianoges, is a good drug. Problem is that sometimes it causes irregular bleeding and spotting, unpredictable spotting. And this is particularly problematic in Indian scenario because the women, they can't go to temple and they can't do their just religious activities, so they are very much disturbed. Danazol, practically obsolete because it causes severe problems like excess hair growth, voice changes. Sometimes the voice changes may be permanent. Letrozole can be used, but it is said that letrozole should be used as second line of drug because letrozole, or if you use for long period of time, it causes number one osteoporosis, number two it decreases the libido and it causes vaginal dryness. So we can't. Now coming to the GnRH analog. Now in our body, whenever we are talking about drug, we are using the term called analog. So what is meant by analog? Analog analogy means the similarity. If a drug has some similarity, structural similarity with those molecules which are there inside our body, this is called analog. This analog can be of two types. One is agonist, one is antagonist. I think you must have heard of this thing, like particularly in the cardiology segment, like beta blocker. What is this? In our body, there are some molecules like noradrenaline. They act on the beta receptor in our body. For every molecule to act in our cell, there are some receptors. For example, this is the cell, and there is some hormone or some molecule. This molecule cannot directly act on the cell. This molecule has to be taken by some structure located outside the cell. This is called receptor. Then this molecule attaches to the receptor, and this is internalized. Then it exerts the action by various ways. For example, if you talk about insulin binds to the receptor, then this is internalized, then insulin causes intake of glucose inside the cell, so that the glucose concentration in the blood decreases. Now what happens in beta receptor, there are two types of molecules they can act on beta receptor. One is beta agonist, like you must have heard of the drug like buvadilan, pitodin. They are stimulating the beta receptor. These are called agonists. See, both agonist and antagonist have structural similarity with the original molecule. See, both beta agonist and beta antagonist, these are called beta blocker. Both are having similar structural similarity with noradrenaline. But what happens when it comes to the point of agonist? It stimulates the receptor. It mimics the action of the original molecule. Whereas in antagonist, when it binds to this receptor, it blocks the receptor. So that suppose this is the antagonist. It binds to the receptors. What happens? The receptor is blocked. So this original molecule cannot act. What happens when the beta antagonist, the beta blocker binds to the beta receptor? It blocks the receptor so that the noradrenaline cannot act. From the pituitary gland, from the hypothalamus, we have this GnRH, gonadotropin releasing hormone. Then from pituitary, FSH and LH. So it secretes FSH, LH from the pituitary. These hormones act on the gonads. In ovary, it stimulates the secretion of estrogen, progesterone, and in men, in the testes, it secretes the production of testosterone. So, if we can block this GnRH, action of GnRH, what happens? Suppose we have GnRH acts on pituitary. So pituitary gland has the receptor for GnRH. Otherwise, this GnRH cannot exert its action on the pituitary. What happens if we can block this receptor of GnRH? GnRH will not act. As a result, estrogen progesterone will not be secreted. So patient will not have ovulation. Estrogen concentration will drop down. Endometriosis will not grow because endometriosis will not get enough estrogen. Pregnancy is not possible because estrogen is not there. Similarly, if estrogen is not there, because estrogen is required for bone health, there will be osteoporosis. If estrogen is not there, because estrogen is required for vaginal health, there will be vaginal dryness, painful sex. All these side effects will happen. When we don't want action of estrogen, we give this type of molecules, that is GnRH. I will say analog. I am not talking about agonist or antagonist. I am talking about this GnRH. Analog. So there are different indications, like for fibroid we can use, for endometriosis we can use. Some girls, they are having, not only girls, even boys also, they are having precocious puberty. They are getting the puberty at very early age. This is not the desirable thing, so we delay the puberty by giving GnRH. There are some like in breast cancer, estrogen is responsible for stimulation of cancerous growth in the breast. So the oncologists, they are giving GnRH analogs. Prostate cancer also, they require estrogen and testosterone. So they are suppressing the hormone secretion by giving GnRH analog. So first, what happened? The GnRH agonist is simple thing, but we did not have GnRH antagonist for initial days. We initially had only this agonist. Whenever we are discussing about agonist, GnRH agonist is something peculiar. Whenever we are talking about any other agonist, like beta agonist, like insulin agonist, they are stimulating the receptors all the time. Whenever you are giving this beta agonist, it will stimulate the beta receptor. Whenever you are giving some alpha agonist, it will stimulate the alpha receptor. GnRH agonist is something peculiar. Whenever you are giving GnRH agonist, initially it causes flare up, increased secretion, because this is agonist. So there will be increased secretion of FSH initially, for initially say around 2 weeks. So this is the GnRH, say this is the GnRH agonist, and this is the receptor of GnRH agonist receptor. So it binds to the pituitary gland and it causes increased FSH and LH secretion. After that, what happens? This receptor is peculiar because if it is stimulated for prolonged period of time, these receptors are internalized. That is, these receptors are going inside the cell. What happens? Whatever GnRH is there in the blood, it cannot bind to the receptor because this receptor is no longer there. The receptor has gone inside. So how this drug can act? Receptor is internalized. So whatever stimulation you use, the receptor is inside. So pituitary will not get, pituitary will assume that there is no GnRH because pituitary think that, okay, I don't have receptor, so how can I bind to the GnRH? So pituitary will stop secreting this FSH LH. If you continue this GnRH agonist for prolonged period of time, pituitary will remain suppressed. Even if you stop this GnRH, GnRH agonist molecule, pituitary will take at least 1 to 2 months of time to recover from the suppression. Then again the receptors will be upregulated. So this is the basic idea. So GnRH agonist is something different. Agonist does not mean that they will always stimulate, unlike other agonists. But antagonist is simple. Antagonist, they will act on the receptor immediately. They will prevent the receptor to bind to the endogenous GnRH, and from the very beginning there will be stoppage of secretion of FSH. So there will not be any flare effect. This is something called flare effect. Initially there will be rise of FSH followed by fall. But in antagonist there will be no flare effect because from the beginning the pituitary will sense that, okay, this drug is not allowing me to bind to the GnRH.
Means the immediacy of action will be
exactly, there will be immediate action. Now, initially we had this GnRH agonist and antagonist initially for IVF cycle. What happens when we are stimulating the ovaries in IVF cycle, we are giving the FSH. Say for 10 to 14 days we are giving FSH. Say FSH, HMG, whatever be the molecule you are using, 10 to 14 days. What happens? This FSH stimulates the ovaries. Ovary will secrete, the follicle will grow, at the same time estrogen will rise. When the estrogen rises, in ovary, two hormones are playing different roles. One is FSH, another is ELAGOLIX. FSH is needed for follicle growth of the follicle. ELAGOLIX is needed mainly for the final maturation of oocyte, so that the oocyte will be released. If there is no FSH, follicle will grow but eggs will not be released. But what happens if FSH acts on the ovary? Estrogen will rise. This estrogen causes increased secretion of LH from the pituitary. We want LH rise at this age, this time, say after 14 days. What happens if LH rise occurs at this point of time? There will be premature LH surge. What happens? Follicles will rupture. In IVF, we have to collect the eggs. Suppose I am planning to collect the eggs on this day after 14 days, but on 10 day I am finding that eggs are ruptured. Eggs have been released. Eggs are ruptured. So what happens? I will not get any eggs. So I need to suppress this LH. How? I need to give GnRH. Previously we used to give GnRH agonist. Nowadays also we are using it, but not very regularly. So this was something difficult. We have to use from previous cycle day 21, and we have to continue. And initially there was followed by this suppression of LH. But nowadays we don't need this because we have antagonists. So we usually start this GnRH when we know that, because say after day 5 or 6 we know, or if the follicle size is more than 14 millimeter, we know that only at this time LH can rise. So we start antagonist from here and we continue antagonist until we doing the ovum pickup. So this is how we are giving the antagonist. Commonly in IVF, we are using two types of antagonists. The most common one is cetrorelix. Then we have this GnRH. Problem is that we can use it endometriosis also. Short acting, immediate action. Problem is that you have to give daily injection. In IVF, we can give injection, we can afford it because patient is taking maximum 5, 6 or 7, 8 injections. But if you are advising a woman to take injection daily, it's not possible. What happened? Initial days, we did not have any other options. We have to, even if we want this depot GnRH agonist for endometriosis, like leuprolide depot, like triptorelin, or these types of depot injection. Yeah, decapeptyl injection. Okay. Or we had this Zoladex, this type of injection. Take it once in a month, or some injections once in 3 months. Problem is that it suppresses the ovaries for prolonged period of time. Action is prolonged. Even after stopping the drug, the action will persist for at least 1 to 2 months. So, if the patient wants to conceive immediately after stopping the injection, that is not possible. And again, the menstruation will take time to return. And sometimes patients can have severe like this thing like osteoporosis. So sometimes to counter this effect, we had to use like used to call it add-back therapy. We have to add some low dose of estrogen and progesterone so that patients should not have this estrogen deficiency symptom. But again, the problem is that patients have to take it in the injectable form, intramuscular or subcutaneous. These cetrorelix and GnRH, they are not active orally. Why? Because if you are giving them orally, they are enzymatically metabolized in the gastrointestinal tract. They will not reach the blast. Now we got these molecules, like some GnRH antagonist molecules that are available orally. Only thing is that you have to give it daily because the half-life is short. You can give only one drug and you can give the second drug for after 3 months. That is not possible. Good. So the advantage is that, of course, there will be amenorrhea. Patient will not have menstruation. But the advantage over diagnosis is that there will not be any unpredictable bleeding. But of course, some anti-estrogenic side effects may be there, like sometimes the patients can have like bone loss, osteoporosis, but it is not as pronounced as it used to happen with leuprolide or something, because leuprolide has long half-life. and whereas in GnRH antagonist the half-life is shorter. And again, the other estrogen deficiency symptoms like some women used to have hot flush because estrogen is not there. So they used to have menopause-like symptoms, hot flush. Sometimes they used to have this thing that I mentioned, that is the vaginal dryness. These are less pronounced with GnRH antagonists. So because the half-life is short, you have to give it either 150 twice daily or 200 once daily. But again, if we recapitulate, when we can give it, patients with symptomatic endometriosis, painful endometriosis, who are not planning for pregnancy. Now, in the context of IVF, there are some papers who have suggested that instead of this cetrorelix injection, we can try this ELAGOLIX in tablet once daily. Advantage is that it is much cheaper than cetrorelix injection, because cetrorelix injection will cost, one injection will cost around 1500 to 2000 rupees. So this is a cheaper. And another thing is that because it is taken orally, so the compliance will be better. But problem is that we who are doing IVF, we are very much coward people. We don't have courage. We always try to play safe. We don't try to experiment with newer drugs. So until further evidences are coming, so probably we will not use ELAGOLIX in the context of IVF until some other strong evidences are coming. Maybe after 2 or 3 years, maybe it will take some time, but definitely in endometriosis and even in case of fibroids, the GnRH antagonists have role. But of course, when the patient is not planning for pregnancy, and particularly when the patient is very much bothered about the pain, it may be used firstly to avoid surgery, because if the pain is controlled after with use of this molecule, patients may not need surgery. And even if the patient needs surgery, if she does not want to conceive after surgery, we can give it for prolonged period of time. So I'm not going into evidence, theory, etc. So there are a number of evidences that it can be used, but only problem I think may be the cost. So we have to take care of this. This is the fiber, and there is something called outer capsule. When the surgeon operates, he or she just must give incision, give a cut here, and then take out this. With GnRH agonist, leuprolide, the problem is that surgery becomes very difficult, because GnRH agonist causes obliteration of this plane. So when the surgeon enters, this is the uterus, he will find it very difficult to locate the fibroid. So either there may be incomplete removal, so surgeon may remove this and this will be there, or there may be some excess removal of the tissue of the uterus, because surgeon will find it very difficult to appreciate where the fibroid is. But we don't know till now, because ELAGOLIX is something new molecule, we don't know whether ELAGOLIX, of course this problem is not there with other molecules like ulipristal or mifepristone. On the other hand, they can have some other important side effects, but we don't know whether this ELAGOLIX will have this problem or not, because the evidences are limited.